lobar pneumonia. When you sick. If lobar pneumonia, large consolidation, infiltrate more than 3-5 centimeters shadow. You know what normal lung feels? This shadows because negative. Это infiltrate. If lobar pneumonia, infiltrate in bodies, lobe or few lobes. What you see? Inferior middle lobe and partly involved superior lobe. And you see homogeneous density. Homogeneous density. What this patient will have? Not only cough, and cough maybe with in lobar pneumonia. In first day with admixture of erythrocytes. So it's brick brown, rusty sputum. At beginning sick. If so large area of inflammation, what high fever, sometimes more than 40. Oversweeten, very hot. If so large involvement, it's two sort of surface of alveoli. Severe respiratory failure, restrictive type, so not complete inspiration, small volume expert, frequent shallow breathing, maybe more than 25-30, loss of oxygen, hypoxia, and hypertension. Saturation of oxygen, do you know? Test, very easy. On finger or nail probe. Less than 90 maybe. То есть patient need in oxygen support. Because very tachypnea and ineffective. Or intubation sometimes. Not good response on what nasal or mask intensive oxygen blood mixture blood flow. If respiratory failure, central cyanosis or diffuse. Tachycardia, not only tachypnea. High fever. And because here, no here, this side may be visibly decreased. On healthy side, maybe acute emphysema. You see, normally left side of lung. Slightly less right, left lung. I hear what? Widening. Here maybe percussion sound with tympanic tint. No, so-called hyperresonant or both. I hear which sound? Dull sound. If we palpate fremitus vocal, patient say 33 or rather loud, deep speech, you can say. Here, vocal fremitus increase. If clots of sputum not closed bronchi. I hear normal or slightly decreased. This part dilated breathing. Here deeply. And auscultation. Here vesicular breathing. No adventure sound, no rails, more than no crackles, whistles. I hear what will be. Physiological bronchial breathing, if open, if closed, maybe decreased vesicular breathing. And because at beginning and in final stage, not all alveoli filled with exudate, alveoli exudate plus air. Crepitation, in modern terms, is fine crackles. Inspiricra, not changed after coughing. Especially in beginning disease and before resolution. At resolution, this fluid becomes more fluid and maybe suppurative sputum. Вот. And hoarse crackles, wet rails, expiratory, in small bronchi fluid sputum. At beginning, inspiratory, and what? Pathological bronchial breathing or decreased vesicle. Fever without antibiotics intravenous from first second day. Maybe up to 10, 12, 14 days. And next abruptly fall. And patient can die because when fall temperature from 40 to 36, or sometimes to oversweeten, collapse, vascular, a patient can die. Well, that's why all such patients should be in intensive care. Respiratory infusion, intravenous antibiotics. That especially if you're against Streptococcus pneumoniae. More than 90% of people with lobar pneumonia has some strains of Streptococcus pneumoniae, not all. And maybe in any age, in young and in elder. То есть cephalosporins, penicillin group effective. But in reality, if start of treatment is delayed with 2-3 days, and no oxygen support, heart support, very risk of death. More than 5-10%. If proper treatment, especially young, very small mortality, 1-2%. What? Lobar pneumonia, pain may be additionally, because it wasn't surrounding pleural wrap maybe, and in this place, pain, inspiration and coughing.
Doctor, can it be recovered after fully recover? Can fully recover? All right.
Prognosis.
Так, mistake this left lung, а это right. Ну, as you see, was 15 years before, I don't remember.
Doctor, after medication,
Most of patients recover if start of treatment from first day. Вот. If 2-3 days missed, more risk. What? Oh, you see, infiltrate. What this is middle lobe. On right lung, middle lobe. Anteriorly, lateral, inferior, mostly lateral, posterior. The middle lobe. Or polysegmentary, because, but here same focal concern, not only fever and COVID. Here dull sound because you see 5-7 centimeters. Vocal fremitus maybe. Bronchial breathing maybe in this place, or decreased vesicle, and crackles. Fine crackles or coarse crackles. Here usually no pain, because it's segmentary or macrofocal pneumonia. Segmentary and macrofocal pneumonia usually starts gradually. Firstly, symptoms of acute respiratory infection or exacerbation, chronic bronchitis, and if patients don't conduct home regime, no medication, repeated novel cold, in few days, new rise of temperature, cough with more volume of sputum, more dyspnea, and repeating X-ray, first time was good X-ray, no shade, detect shadows. X-ray shadows should be to confirm diagnosis of pneumonia. No, you see, superior lobe. And very good visible involvement intralobar pleura. What? What's the right lung? And this is the left lung. Same, the severe conditions. What? You see? Lateral projection of middle lobe pneumonia. But in this situation, what? Because middle lobe, сколько? 2 segments. Inferior lobe, mostly on the right, laterally inferior. On the left, inferior lobe not present. Это part of, это вот lobar pneumonia. Other pictures I show focal. No prominent dyspnea, no prominent fever. Sometimes only very few crackles or dry rails, rhonchi, locally. And only X-ray help. Well, you see, if typical focal pneumonia, small shadows, because maybe only lobulus involvement. Lobulus, you see? Это subsegmentary stripe, maybe half, and between infected lobulus, maybe normal tissue. And that's why shadow not homogeneous. More frequently what in inferior lobes. Not homogeneous, you see? Especially patients who have heart failure, chronic lung disease, what? Decreased immunity.
Doctor, excuse me, is that pathology side? That
What?
no, in the left side.
You see, focal pneumonia, shadows not so densely, not homogeneous, not so distinct bodies. What? Compared to such. You see, here complete lobe involvement, homogeneous density. Bodies of shadow, light shadow, infiltrate in the bodies of lobe, usually of lobes. I can't. By such pneumonia, very few small foci, especially at first day, by what plain X-ray may be missed. With computer tomography, lung CT, more sensitive and specific. What? You see many shadows. If involvement of lung apex, superior lobe, we need to exclude tuberculosis, because especially if patient has chronic cough, repeated chronic subfebrile fever, wasting, because tuberculosis affects most frequently superior lobes of both lungs. And we need to examine not only usual sputum test, a special medium to culture tuberculosis, delayed growth, 1 to 2 months, or to test immunoenzyme or polymerase chain test on antigens of tuberculosis. Answer tomorrow maybe. Especially if patient had contact with tuberculosis. What you see? And increased bronchoscopy pattern because bronchitis, acute or exacerbation of chronic, usually previous to focal pneumonia. And shadows not distinct between, because between lobulus is exudate, normal lobulus. Here maybe only hyperresonant percussion sound. If deeply no fremetus vocalis and bronchophone increase. Here, only decreased vesicular breathing, or if on the basis breath, opposite, hoarse, intensified with prolonged expiration, and maybe raunchy, wheezes, not only wet crackles. Wet crackles moderately, wet rails, это moderately cause crackles. Or crepitations. Well, that's why if fever prolonged, most sputum, repeating rise of temperature in few days. Radiographic examination to exclude focal pneumonia. Focal pneumonia. More intensive antibiotic therapy than usual acute bronchitis. Usual acute bronchitis may be oral antibiotics. I here we need, if the spare blood test show high CRP, high procalcitonin, look at the intravenous antibiotic, or incomplete recovery maybe with focal fibrosis. Dyspnea usually not so prominent. You see very large left ventricle. Yes. If left ventricle failure, patient usually has congestion in inferior lobes of lungs, and here repeating focal pneumonia with development pneumofibrosis. This is why such cases bilateral decreased vesicular breathing, bilateral crackles, hoarse crackles, wet, or crepitation, or respiratory crackles, cough with sputum. And if repeating pneumofibrosis, how we differentiate? Here pneumofibrosis with congestion, or on its basis, focal bilateral congestive pneumonia. That pneumonia, leukocytosis maybe, left shift leukocyte 4, elevation CRP corrective, elevation procalcitonin, prohormone, parathyroid glands, but very sensitive on bacterial fish. More cough, if only congestion, cough dry, and serous sputum, white, or if infection, mucopurulent, pus sputum, fever and congestive pneumonia may be absent completely. Now, in this patient, you see, have very expressed bronchoscopy pattern. And what? You see left lung more than right. Why? You can speak that here not only chronic bronchitis with right side pneumonia, here maybe что? Partial obstructive atelectasis on the right. Which patient needs bronchoscopy, because maybe что? If this situation acutely, maybe что? Clots of viscous sputum in right main or large bronchi, lobar bronchi. А maybe что? Cancer. Cancer maybe. А maybe clots of sputum, foreign body. Bronchoscopy very important. If obstructive rectal here decreased vesicular breathing, this side decreased shallow respiration, delayed, and you see dull or hyperresonant percussion sound, but if you see that right lung less and shift medias to the right, very likely on cancer. Cancer of large bronchi. Same cough maybe with sputum, fever. In this segments. Maybe pneumonia secondary. But you see here, decreased translucency, dull sound maybe, or hypervisual. On the basis, focal consolidation, maybe cancer, tuberculosis, we need an additional test. No. Это local pleurisy. А вот здесь you see shadow, round shadow in lung. Maybe focal pneumonia. А what maybe, with which we defeat? Cancer, peripheral cancer of lungs, alveolar origin. Maybe at any patient, not only at smokers. Sometimes patient in health way of life for many years. Maybe tumor metastasis, malignancy maybe там, abdominal cavity, kidney, mammalian gland, thyroid gland. No, even upper lobes, tuberculoma maybe. More specific, contrast computer tomography. No, and to take test if tuberculosis, sputum test or bronchoscopy, take bronchial coil. Malignant cells may be detected. Pleurisy may be frequently like complication pneumonia. Это вот encapsulated, localized pleurisy, because here adhesions restricted. Maybe result of incomplete resolution of pleurisy with effusion. Patient needs here in antibiotics and with control ultrasonography, target puncture to evacuate, to introduce. No, same. Increase bronchoscopy pattern. Low domus usually domus diaphragm side. Это maybe что? Chronic obstructive pulmonary disease. Mainly bronchitis. No local shadows. And to see what non-homogeneous shadow, here no, maybe focal bilateral pneumonia. And you see heart near triangle. But here no, if exudate in pleural, pericardial, homogeneous. Дальше. А here что? Enlargement right and left heart bodies. Which on the basis chronic heart failure is congestion, maybe congestive bronchitis. And on this basis, maybe so bilateral congestive pneumonia. Shadows you see non-homogeneous, non-distinct bodies. Here maybe what similar situation, increased bronchoscopy, some shadows, small shadows. No, maybe focal pneumonia is the basis, congestion of chronic bronchitis, chronic obstructive pulmonary disease. You should understand that X-ray is only one of the techniques. One same small focal shadows. And you see increased translucency. Very dark, white interspaces. Here emphysema maybe. Emphysema, chronic obstructive pulmonary disease variant. And on this basis maybe focal pneumonia. to a distance that here no prominent dull sound. Maybe if small deep foci, symmetrical resonance sound, maybe very small auscultative data.
Can't it be a pneumothorax?
Pneumothorax. In pneumothorax, you will see no completely lung pattern. And you will see that here only and compressed root to lung. Here you see bronchoscopic pattern present. Here emphysema. If I find pneumothorax, I show you. What? No, here not complete. Same, very wide interspaces, emphysema. And what? Shadow in the right lung. Inferior, maybe middle lobe. And increased bronchoscopic pattern, which on the basis, maybe for pneumonia. Non-homogeneous focal pneumonia. Not shadows. No, here, maybe tuberculosis. Or what? Shadow. What? Enough lobes. On the base, same. Chronic bronchitis. Increased bronchoscopic pattern. No, I show other, maybe, some pleurisy. Very large. No what? It's a complete diffusion. You see, homogeneous they completely. Infusion in pleural cavity. What? Правый. What? On the right. Mediastinum shift to the left. And you see here multifocal consolidation. Maybe pneumonia. Only what? Superior lobe of right lung ventilated. Here maybe or total pleurisy or total hydrotalk. How examine and to help patient initially. Puncture should be. We evacuate. No, for one time, not more liter. If more, very short returning and refractory shock or collapse maybe. We Syria and examine fluid. If more protein than in blood serum. If increased density, rival test positive, high lactate heterogenease level more than issue. If many leukocytes, here with pleurisy. Oh, here pneumonia, I think. So, without puncture, patient very suffer restricted respiratory failure because very small vital capacity. Patient need an oxygen. But here complete dull sound, no breathing, no vocal fremitus, bronchophonia. Hydrosorax. If hydrosorax, usually upper limit of fluid horizontal. If wet pleurisy, upper limit of fluid oblique at most height on axillary line. Why? Here no inflammation, no restriction, upper limit of fluid by adhesions. Adhesion, inflammatory adhesions. In wet pleurisy, adhesions restrict more fluid to media, unless here, because let's hear oblique line of the muzzle. То есть here dull sound, no breathing. Here upper, vesicular, and resonant sound. А вот here bend of compressive exercitations, 2-3 centimeters absent. Here compressive gives not loud but tympanic sound because air in bronchi not so compressed like alveoli. And atelectatic bronchial breathing bend. What do you see? Displacement of heart to the left, very large left heart chamber, smooth waist to the heart. То есть here maybe mitral regurgitation. If mitral stenosis usually more left way. And here complete, here effusion. And here you see compressive atelectasis. Upper limit of fluid, not very deep, but I think slightly more here. More the puncture and test of fluid find exudate. And here compressive and maybe pneumonia. Same patient needing puncture and oxygen support. Such patients usually better respirate on this side. Because even this side compression goes lungs. То есть patient with pleurisy usually dry because decreased pain, with wet because here no properly. In bed on this side, on affected side. Right. So very large heart, the similar case. But fluids here more gore. I here compressive atelectasis. And I think on the basis heart failure. Nitrothorax frequently on the basis heart failure. Maybe in other diseases with what? Renal failure with oligoly. A site may develop at hydrosol. Liver cirrhosis. Maybe on the basis cancer. Well, here, bilateral effusion. I think more than this hydrothorax. Triangle heart. Here maybe hydropericardium. Increased bronchoscopy pattern, maybe not only because chronic obstructive cardia, maybe because chronic congestion in heart, especially left ventricle failure. But what here maybe puncture under the control ultrasound. And we can examine fluid. Ну это you see round shadow and here what is the level of fluid? Here abscess after beginning of drainage. Before drainage, here rounded shadow. And we cannot differentiate. If here abscess before drainage, or tumor, or tuberculoma, or focal pneumonia, after drainage, good visible. Usually such patients after drainage have decreased fever, cough with large volume of sputum, suppurative sputum. Right here you see congestion of both lungs, increased bronchodilatory pattern. Maybe, because heart not enlarged, more than on the basis chronic bronchitis. Tuberculosis, same maybe. Tuberculosis abscess called tuberculosis cavern. Cavity, cavern. So sputum should be examined and tested. You see, same enlargement of right-left contour. And very congestion in both lungs. Heart failure, I think. Heart failure. Same on this basis, maybe что congested focal pneumonia can develop. No, это, you see, not all dome of devil, because here emphysema, white emphysema and increased bronchovacuum, chronic obstructive pipe. And here you see small indistinct shadow. And 1, 2, 3. Maybe on this basis, or chronic pneumonia, or chronic bronchitis with pneumosclerosis. Because repeating pneumonia, focal pneumonia frequently. If focal pneumonia, more sputum, more inflammatory response. Да. Вот. Displacement mediastinal to the left. And what? You see oblique line. What here? Exudative pleurisy. And maybe what? Same bilateral heart failure, right and left heart sided. Same maybe here what? You see non-distinct shadow. CT confined in some such cases pneumonia, focal pneumonia. Same enlarged left smooth waist of the heart. What waist of the heart should be here. Maybe congestion in both lungs. Without X-ray and computer tomography, you don't confuse. Белок protein. If more than 3 grams per liter, more for exudate. Less 3 gram, transudate. Next test. Удельный вес, wood вес, specific gravity. Less than 1020, transudate, because less protein. More than 1020, exudate. Next. Проба Ривальта. Ривальта say. Sensitive test chemical or mucocirrhosis, protein that very much in exudate. Positive, положительный, exudate. No, and in exudate more leukocytes. What here splash total, usually more than 10-15. What compare here with my test. What do we see? Here specific gravity only 1012. Protein это less 100 грамм. Это 100, а тут 80. 25 сотых borderline. Rival test negative. What here transudate. And here leukocytes 5, 6, and here total. No, and in new textbook, and in lecture for pleurisy, was light criteria by family scientists. Light criteria это Michael, it's in lecture presentation and in new textbook. Chapter 1, lactate dehydrogenase, enzyme that very much in blood cells. If exudate pleural fluid, lactate dehydrogenase, more than 2 shots of serum lactate, and similar protein, pleural fluid, more than 2 shots of serum. In exudate more protein, more lactate dehydrogenase. This test is a old test. But here, for example, you see exudate protein 30 gram, specific gravity more than 1020. You see, very much, rival test positive, very positive. Many inflammatory, and you see atypical cells. Why? Because cancer, malignancy, pleurisy may be not only infective, primary infection or complication, pneumonia, tuberculosis, or maybe on the basis cancer. Maybe on the basis severe uremia, severe renal failure, accumulation, crystals, urea, creatinine, uric acid simulated. Вот. То есть это malignant pleurisy, malignant exudate. Here transudate, exudate. Rival positive, leukocytes more than 10, protein more 32. And specific borderline. Maybe patient very undernourished. If low protein in blood serum, maybe not very high. And what remember, like criteria, lactate dehydrogenase elevate in exudate and protein. Maybe here some mistake. You can see the O2 lecture. Lecture will be used. And present in textbook part 1. Because in this year, MCQ for exam will be changed. All and light criteria will be in one of the questions because this is modern standard to any exudate restudic, maybe a side or maybe neither pericardium or pericarditis. Have you question? No. Right. Next class, acute rheumatic fever.